In this presentation, we'll be discussing disseminated intravascular coagulation, or DIC. We're going to be discussing what DIC is and how it might present in our patients, and then how we take care of these individuals. So in order to understand DIC, we must have a clear understanding of the coagulation cascade and clotting factors. And if you haven't watched that introductory video, please be sure to watch it now. Now remember, clotting factors are actual proteins floating around in your bloodstream, and we have to have a good supply of these factors in order for the clotting cascade or the coagulation cascade to work. And if we're low on factors, the coagulation cascade won't happen efficiently. It'll be slower and take longer, and therefore we will have less fibrin, which means fewer clots and higher risk of bleeding. That's really important to understand. Now, other important things to be aware of. Normally, the coagulation cascade is triggered due to a specific local event. You cut your elbow and the coagulation cascade happens locally at your elbow. And when the coagulation cascade happens locally right there at your elbow, you use up clotting factors that were floating around in that area. So let's take a second to think about this. What if a patient had a lot of coagulation going on? And not just locally, but what if the coagulation was in hyperdrive, going on all over the body, if it weren't just happening locally? If that happened, then not only would we end up with a lot of fibrin and clots all over the body, but because the coagulation cascade uses up clotting factors when the cascade is going, we would also start to use up factors in this widespread coagulation as it's going on all over the body. So if we had widespread coagulation, we would soon start running out of clotting factors and running low on clotting factors. And looking at what we just learned, if we're now low on clotting factors, we are now at risk for bleeding. This is how a coagulation problem could lead to a bleeding problem. And this is often not easy to process. So take a second to pause the presentation here if you need to, just to read through this one more time. Because this widespread clotting leading to depletion of clotting factors causing a bleeding problem describes a lot of what's going on in DIC. So now that we understand those key concepts, let's look at DIC. Now, DIC is both a bleeding and a clotting problem. So here we see our definition: a serious bleeding and thrombotic disorder that results from abnormally initiated and accelerated clotting. Subsequent decreases in clotting factors and platelets ensue, which may lead to uncontrollable hemorrhage. Now that definition kind of describes some of what we just talked about in that last slide, so let's break it down. First, DIC is due to abnormally initiated coagulation. Something, and we'll talk about what that something is soon, but something is triggering this diffuse coagulation to happen all over the body. So as we now know, if someone has coagulation not just happening locally, but widespread, this disseminated coagulation, that's going to require a whole lot of clotting factors. We're coagulating all over. We're going to need clotting factors for that chain reaction to happen all over the body. Now keep in mind, we didn't ask for this coagulation, right? We don't need all of these little clots to be created all over the body. This was abnormal. Something caused our coagulation cascade to go into hyperdrive all over the body. So right away, we have our first problem: a whole bunch of clots that we didn't need floating around. That's our first problem. Next, because we've created all of these useless little clots all over the body that we didn't even need, we have another problem. We've now used up a bunch of clotting factors. We've essentially wasted them. A whole lot of inactive clotting factors have just been activated and used up to make a whole bunch of clots that we never needed in the first place. So our second problem is, if we happen to need a clot somewhere, if we needed coagulation cascades to happen, let's say when drawing blood or at an injury site, this patient in DIC can't effectively make clots at that specific site because clotting factors that we need to make the coagulation cascade to happen, those factors have been used up to make all those useless little clots all over the body that we never needed. So you can see we have a clotting problem and a bleeding problem. Now we have bleeding and clotting problems for additional reasons that we'll go into shortly, but these are the major things to understand about DIC. Now, if you'll recall, in order to make a clot, We need that fibrin from the coagulation cascade, but we also need platelets to get caught in those little fibrin strands or those nets to form a clot. So we have factor depletion because those factors were being used up in the coagulation cascade. And now we also end up with platelet depletion because those platelets that used to be just free floating around the body in the bloodstream are now getting caught in all of those little clots. So when you measure someone's total platelet count, it has dropped significantly because many more platelets now are getting used up in all of those little clots all over the body as well. So you can see we have two major problems: diffuse coagulation that was triggered by some underlying condition, and these tend to be smaller clots or microclots, and then profuse bleeding from depletion of clotting factors and depletion of platelets, because we just made a whole bunch of clots that we didn't need. So just to summarize, DIC is triggered by some underlying cause. That trigger causes this widespread activation of the coagulation cascade. That causes a whole lot of fibrin to be created all over the body that we didn't really need, and it uses up clotting factors. So now when we actually do need fibrin and we do need a clot somewhere to stop bleeding, we don't have enough factors to create the fibrin that we do need. And that is why we have, in one patient, a lot of clotting causing problems and increased risk for bleeding with potential hemorrhage. Now, as mentioned before, that first introduction to DIC is a little oversimplified, but that is the general process of DIC. However, let's look into more detail of the pathophysiology behind the microclots being formed, as well as the pathophysiology behind the bleeding issue. So starting with the patho of the thrombi being formed. DIC happens because something has triggered the coagulation cascade, and we'll discuss what could cause this in more detail soon, but we often look at this as big systemic things or big shocks to the body, so things like severe widespread trauma or injury, and even specific cancers that cause increases in tissue factor. Remember, tissue factor triggers the extrinsic pathway of the coagulation cascade. But again, this trigger enhances our normal coagulation mechanisms, abnormally triggering the coagulation cascade. Now, as part of the process, platelet aggregation is also enhanced to form all of these microclots. Now, where did all of these microclots go? All of these useless little microclots don't just stay floating around in the bloodstream. They land. They end up somewhere, and many of these tiny clots go into tiny vessels and plug those tiny vessels. So they might deposit in the capillaries or arterioles in a patient's kidney or liver or even their brain. And these organs, and all of our organs, really like blood flow. They need oxygenated blood to function. Well, if we have all of these tiny clots progressively blocking blood flow to organs, we can start to see multi-organ failure. We may also see thrombus formation in smaller vessels in patients' toes and fingers, leading to tissue damage as well. Now let's take a deeper dive into the pathophysiology behind the bleeding problems with DIC. We've discussed how excessive clotting has been triggered by an underlying condition, but what we haven't discussed is that when the coagulation cascade is triggered, it has its own mechanisms that are simultaneously triggered to kind of keep the clotting in check. Remember, normally the coagulation cascade has to really work with a delicate balance of enough clotting with enough bleeding. So in normal times, once it's triggered, the fibrinolytic or fibrin breaking system is also activated. And this is just so that we don't create too many clotting problems as the coagulation cascade is triggered in normal times. However, when we're in DIC, the fibrinolytic system is activated more broadly, just like our coagulation cascade has been triggered more broadly. So while we're seeing all of this fibrin being created, we're simultaneously seeing all of this fibrin being broken down. And when it's broken down, there's these little pieces of what I like to refer to as fibrin garbage, these chunks of fibrin that have been broken down. And that fibrin garbage is traditionally referred to as fibrin split products. Sometimes these are referred to as fibrin degradation products or FDPs, but we usually hear FSPs or fibrin split products. Now, why do we care that there's a bunch of broken up fibrin floating all around in the blood? Well, these FSPs or FDPs aren't actually just garbage. they can still do something. And these FSPs actually inhibit normal coagulation. So now we have a combined issue of lots of FSPs inhibiting normal coagulation while we've already depleted clotting factors due to all of this clotting going on all over the body. So considering all of this, the blood now loses its ability to form a useful clot in places where we need it. We can't form a stable clot at injury sites, and therefore patients are at high risk for hemorrhage. So we hopefully have a clear understanding of how patients with DIC can end up with a bleeding problem and a clotting problem simultaneously. But I've kind of been vague about what could trigger the widespread activation of the coagulation cascade. So here you can see some common causes. We see shock, septicemia, hemolytic processes, like something you might see that could be triggered by a blood transfusion, obstetric conditions, maybe like abruptio placenta, significant tissue damage. And we mentioned how certain malignancies may trigger DIC. This also goes along with chronic conditions, so often cancers and autoimmune diseases, for example. Just keep in mind, DIC can be chronic, just like these chronic disease processes. And in those cases, DIC is managed in a more chronic state than what you might see in an acute state in DIC, maybe suddenly in the ICU after a patient goes into septic shock, for example. So chronic or subacute DIC is more commonly seen in these patients with long-standing illnesses, and patients may just bruise more easily or possibly even hemorrhage, and some may just have hypercoagulability, while others have significant thromboses. So additional possible causes for DIC include transplant rejection, post-operative complications, and actually many, many others. I recommend reviewing your textbook for an exhaustive list of causes, but here we've isolated a few of the most common ones. So now that we understand what causes DIC and how they end up with bleeding and clotting problems, what will they look like? Well, it's not actually very complex if you think about it. We're looking at those two categories of clinical manifestations. What could a patient look like if they were bleeding, and what would a patient look like if they were clotting too much? So starting with bleeding, there are a lot of ways and places we can bleed. Integumentary is probably one of the most obvious places. So we might see actual oozing or blood, maybe from a venipuncture site or hematomas. Remember those tiny little pinprick bruises called petechiae? Those are from broken capillaries. Or we might see purpura, those larger spots of pooled blood under the skin. Hemorrhage can also be hidden, so occult hemorrhage, where we can't see any bleeding, but it is occurring. And now, what does someone look like overall when they've lost a lot of blood? Well, they often look very pale. So remember, signs of bleeding aren't always about the blood. It's what someone looks like when they've lost a lot of blood. Next, looking at the respiratory system, if blood is pooling in or around the lungs, it's harder to breathe. So patients may have a faster respiratory rate, they may actually cough up that blood, or when they lay back and lay flat on their backs, the blood pooling makes it even harder to breathe, causing orthopnea. Now with the cardiovascular system, if our patient has lost a lot of blood, they're hypovolemic. So our patients will present with hypotension due to that volume loss, and tachycardia, showing our sympathetic nervous system trying to compensate. The gastrointestinal system can bleed too, so bleeds in the upper and lower GI can occur. Depending on where the bleed is, the signs and symptoms may vary. So for example, a high upper GI bleed will look like frank red blood. Maybe the patient vomits up red blood. However, an upper GI bleed that's a little lower, maybe it's in the stomach, well, that blood is getting digested a little bit, so it's going to change color and it'll look like dark coffee grounds. Now for lower GI bleeds, again, we consider digestion and the location. So if the bleed is very low in the lower GI system, that blood isn't really getting digested, so it's going to look like frank red blood in the toilet. But if we're having a lower GI bleed that's a little higher up in the intestines, now again that blood's getting digested a little bit more, so the patient's stool would be black in color and kind of a tarry consistency. And also blood takes up space, so if we have internal bleeding in the GI tract, the patient's belly might be distended and painful. Now moving to our genitourinary system, we might see blood in the urine or hematuria. Just keep in mind, we can have blood in the urine and not actually see it with the naked eye all the time. So this is why a urinalysis is so important. And then neurologically, our patient may have vision changes or present with some of the signs of hypovolemia and poor perfusion, like dizziness, headache, changes in metal status, and irritability. Blood is very irritating when it pools around brain tissue, so that can account for some of these symptoms as well. And then similarly for musculoskeletal, blood pooling around the joints and around the bones can be very irritating and cause our patients pain or even deformity. Now, what would a patient look like if they have too many clots, if they have a thrombotic issue? And a helpful way to think of this is just to consider what happens when blood flow is interrupted in a lot of different places in the body. So with the integumentary system, interrupted blood flow can lead to cyanosis and even tissue death. And there's something called hemorrhagic necrosis, which is when blood has pooled around dead tissue or necrotic tissue or organs, and it appears that it's bleeding even though the tissue does not have sufficient blood supply. And then looking at the respiratory system, if we have poor perfusion to the lungs, this can trigger symptoms of a pulmonary embolism, so tachypnea, dyspnea, chest pain, and so on. And damaged lung tissue due to poor perfusion can also send a patient into acute respiratory distress syndrome, or ARDS. And when we see poor perfusion in and around the heart, this can affect the EKG as parts of the myocardium are injured or even infarct. If blood's backing up due to poor perfusion or blocked blood flow, venous distension may be noted in our patients as well. Now, a poorly perfused GI system can lead to non-functioning sections of the bowel that do not have peristalsis and can become enlarged. And this is what we see with a paralytic ileus, and as you can imagine, could be very painful. Now, poorly perfused kidneys will begin to suffer tissue damage, and kidney damage can present as low urine output and ultimately lead to something more serious like kidney failure. Patients with DIC will often have frequent laboratory testing, so we can identify what may have caused the DIC, determine how severe the case is, see how our patient's progressing or worsening, and ideally treat the cause. Now, this testing is often done several times rather than just once, so we can monitor trends in our patients. And as you can imagine, if this testing requires poking our patients with a needle to draw blood, we may get to a point where we look at the risk versus benefit. And this is why a central line or arterial line may be considered for a patient with DIC, so we can do those frequent blood draws. Looking at some key labs here, let's try to understand what we might see in our patient with DIC and why. Now, a lot of what we will see is explained by this widespread coagulation creating a lot of microclots, which uses up a lot of clotting factors and platelets. So when we draw that serum platelet count, the total count is low because a lot of these smaller platelets have been used up in clots. And we will see that a lot of the free platelets are larger because remember, the majority of the clots floating around are microclots. Now, also in the patient's blood smear, some of the red blood cells have been damaged or fragmented due to getting caught up in these clots or getting sheared in the clot formations. So we see an increase in these fragmented RBCs or schistocytes. Also, because increased coagulation uses up factors, all of our factors will be low. We often measure levels of fibrinogen, which remember is just factor 1, and these levels tend to be low because they've been used up in the sense due to DIC. And then we can also look at bleeding times, so PT or INR or PTT or APTT. Remember, these tell us how long it takes to move through the coagulation cascade, measured in seconds. So bigger numbers are more seconds or longer times. So if we've used up a lot of coagulation factors and we aren't going through the coagulation cascade as efficiently because we don't have as many factors, then it's going to take longer. And all of those associated bleeding time lab values are going to be high, a large number of seconds. So you can see that a PT is often over 15 seconds, which is high. An INR is actually just an adjusted ratio of PT, but it's reflecting the same information. That's also going to be high, over 1.2 seconds. And the PTT will be over 60 seconds, and that APTT, which is derived from the same information as a PTT, that's going to be long too, so over 40 seconds. Now, another aspect of the pathophysiology of DIC that helps explain our other lab values is what happens when fibrinolysis is triggered, and all of the fibrin that was created starts to be broken up and creates those fibrin split products, or FSPs. Well, there actually are specific types of FSPs, and they have names, and one of those specific names of FSPs is called D-dimer. So when we draw our patient's blood, we're going to see a lot of FSPs and therefore a lot of D-dimer or high D-dimer. So how might we take care of a patient with DIC? One of the most important things we can do is to identify DIC as early as possible. So therefore, it's important we know who's at risk and then to watch closely for those subtle signs of bleeding and clotting. This means frequent assessment of the skin, venipuncture sites, and mucous membranes. We also need to closely monitor for signs of bleeding and clotting, such as hypotension and tachycardia, changes in mental status, increased abdominal girth or pain. We also need to watch for signs of thrombosis, which could manifest as organ damage. So, for example, oliguria could be a sign of kidney damage due to microclots reducing perfusion to the kidneys. Now, because our patients have trouble breathing, either due to blood pooling in the lungs or potentially pulmonary emboli, sitting them up in semifowlers will enhance ventilation. We're also going to closely monitor those lab values just discussed and watch for trends that will tell us how our patient's doing. Hydration is really critically important for these patients with DIC for multiple reasons. They may be hypovolemic due to bleeding, and hemoconcentration that happens due to dehydration increases viscosity of the blood and blood that's really hypercoagulable. So we need to keep a close eye on our patients' eyes and O's. And then because these patients can be critically ill, it's important to promptly administer prescribed therapies to increase our patients' chances of survival and recovery. Now, if we're considering how critically ill these patients could be, let's look at airway, breathing, and circulation and our collaborative care. So as the team cares for these patients with DIC, we must all be watching for one of the most severe complications of DIC, which is hypovolemic shock. So watching for that hypotension and tachycardia in addition to other signs of hypovolemic shock. For airway and breathing, this patient may need stabilization with oxygen administration, but we should also be watching out for respiratory distress by closely monitoring their ABGs and their oxygen levels. And while all of this management is going on, the only way we're going to resolve this DIC problem is to treat the underlying cause that triggered it all in the first place. And sometimes that's not an immediately achievable goal, but it needs to be clear in the patient's plan of care if at all possible. Now, some patients may present with more thromboses or fewer thromboses. Some patients may present with a lot of bleeding or very little bleeding. As we individualize our care, we need to work with the team to control both as we are able. And if a patient is not bleeding, we focus on treating the underlying cause and less on the symptoms of the DIC itself. We may also administer heparin to reduce consumption of clotting factors. And if the patient is showing signs of bleeding, we focus on this possibly deadly situation and administer specific blood products. So what might some of those specific blood products be for a patient that is showing signs of bleeding? Now keep in mind, we do not just give everybody blood products that has DIC. We need to make sure the benefits outweigh the risks of a transfusion. So 3 common types of blood products that can be used in life-threatening hemorrhage due to DIC include fresh frozen plasma, or FFP, platelets, and cryoprecipitate. Now, FFP contains clotting factors. Remember, we have a coagulation problem happening all over the body. We're using up clotting factors in DIC. Replacing those clotting factors will help us when we actually need to make a clot. So if our patient is low on clotting factors and maybe they have a really high PTT or a high INR and this coagulation is taking way too long, causing a lot of bleeding, giving our patients clotting factors can help the patient clot more effectively. But as you might realize, we aren't solving any problems by giving them FFP. We're essentially just giving them clotting factors so that they can be used up again. So this is why FFP is given to patients who are bleeding. We realize we are not treating the cause, but if we don't treat this bleeding problem, the consequences could be very serious or deadly. Now, similar to FFP, you might also be giving cryoprecipitate to patients, and cryoprecipitate replaces specific factors, so factor 8 and factor 1. And remember, factor 1 is just also known as fibrinogen. So depending on the patient's pathology, cryoprecipitate may be administered to replace those depleted factors in the case of hemorrhage. You'll also recall that our patients will have a low platelet count because many of those platelets have been caught up in these microclots all over the body. And again, we can administer platelets so that they can be available for clots that need to be made in the case of hemorrhage. Now note, the platelets are not in FFP, and FFP is not in the platelets. So to give clotting factors, we administer FFP. To give our patients platelets, we literally give them a unit of platelets. And the same rules apply as before. We aren't resolving the cause still. Those platelets we give them are likely going to be used up pretty quickly, and we'll kind of be back where we started. But just like the FFP, If my patient's bleeding in this moment, giving them platelets will help them with that present problem. Now, also, still in the mode of treating symptoms and not really treating the cause, we may also give patients red blood cells. And if they're hemorrhaging and showing signs of hypovolemic shock, for example, that patient not only needs help clotting, so we'll give them maybe FFP, cryoprecipitate, or platelets, but they also just need blood that they lost to be replaced. So red blood cells can be administered in those cases. Now, there's also collaborative treatments related to the coagulation cascade itself. And the two treatments we discuss here relate to things that actually happen naturally in the coagulation cascade. And that's the concept of antithrombin. An antithrombin is a naturally occurring substance in the body that actually goes and deactivates a number of specific factors in the coagulation cascade. Essentially, it puts those factors back to sleep and slows down the coagulation cascade. So these two treatments, heparin and antithrombin 3, basically imitate this process. Heparin works with antithrombin in the body to deactivate factors more efficiently. And as you can imagine, antithrombin 3 just does the work of antithrombin in the body. So we just have more antithrombin doing more work. Now, let's take a second to think about this. Why? Why would we use antithrombin or accelerate antithrombin in someone with DIC? This person already has a slow coagulation cascade. Remember their high PTT or their high INR, for example? It's already taking a long time because we're short on factors. Why would we want to deactivate factors and slow this down even more? Well, the reason would be that we want this because it limits the use of the few factors that we have. By deactivating them, we're in a sense limiting the widespread coagulation going on all over the body. We're deactivating the tools needed to run the coagulation cascade all over. Now, this is not a treatment for every patient because, as you can recall, heparin and antithrombin do essentially increase risk for bleeding. We're limiting our ability to form a clot by deactivating these factors. So these treatments are only reserved for patients where the clotting is the main problem and the benefits of the treatment outweigh the risks for further bleeding. Now, you'll also remember that at the beginning of this presentation, we mentioned how not all DIC is acute and sudden. Some patients suffer from chronic DIC. And in those cases, patients may receive heparin treatments as needed, but we found that oral anticoagulants, maybe something like Pradaxa or warfarin, those oral anticoagulants are often not effective treatments for chronic DIC.